Jonathan, you've been waiting patiently here, and the floor is yours to try and explain to us a little bit about your model of virtual care in rural Eastern Ontario.
Thanks, Peter. Happy to do so. And Francis, my apologies for interrupting there. I have an event which is even more important than this one. My 8-year-old birthday party starts shortly, so my apologies that I do have a hard stop on that one. So I'm a family doctor in Renfrew County, which is, as Peter said, is just to the north of Ottawa. It's actually the largest county in Ontario. I know when I talk about large geography, Sarah probably raises her eyebrows a little bit, but in my context, Renfrew County is big. A population of about 108,000 people. Compared to the rest of Ontario, the demographics of the population, it's an older population, it's poorer and sicker, so higher rates of chronic disease. We also have a really terrible problem with attachment to family physicians, so unattachment, meaning no family doctor and no alternative primary care provider. So about twice the provincial rates. We run at about 20% unattachment. And there are no walk-in centres, no urgent care clinics. So if you have an urgent health concern, your options for literally tens of thousands of people are go to an emergency department or don't get healthcare. Like I say, my background is as a family doctor. I'm also an assistant prof at the University of Ottawa. I have a research program in using virtual care as a means to improve access to primary care, particularly in rural, remote, and underserved communities. And at the start of the pandemic, we set up a system called VTAC, or the Virtual Triage and Assessment Centre. So it was established as a COVID centre, and it's evolved along the way, but it's still fundamentally, funded and has policy approval as a COVID assessment centre. So all of that side of things, triage, assessment, testing, is done on the ground by paramedics, community paramedics. We have an extensive network of community paramedics in the county. And we have family physicians at VTAC working virtually. So they provide predominantly phone, but also video capacity, but phone assessments from a family doctor, in-person assessments from a community paramedic, and a really well-designed and integrated network with existing local resources. And what we've been able to do is tap into the synergy of family doctors and paramedics working together. My buzzword is hybrid. And we talk about VTAC as a hybrid of hybrids, so virtual and in person, paramedics and family doctors at home and in clinic, because we also have a network of sites across the county where the paramedics are providing in-person assessments, and then they have a live video link to a family doctor that they can access at that point. Along the way, we said, well, how do we move along that sort of urgent care? Because really the tagline for VTAC is if you have an urgent health concern, you don't have a doctor, or you can't access your regular doctor, rather than going to the ED or not getting any help, call VTAC. So acute episodic care. And then what we sort of thought was, well, how can we go that next step? So many people unattached. Is there any capacity to have an attachment option, so at least some of those people can get attached to comprehensive team-based care with a family physician leadership? And so the integrated virtual care program taps into one of our family health centres, similar to the CHCs that Francis was talking about. So salaried physicians that we can recruit now, because the physician works predominantly remotely. The family health team, nurse practitioners, other doctors, and all of the allied health that you're well aware of work in the local community. So the patient knows who their doctor is. They know that perhaps they may never meet their doctor, or they may rarely meet their doctor. They'll get their care virtually, but their doctor is responsible for coordinating everything and for being that first assessment with them by phone or video. But then if they need in-person care, they can access that at their local clinic through another member of the group, be it a physician, an MP, or allied health. And so we feel that absolutely meets that criteria of comprehensive team-based care with family physician leadership. And right now we've got over 2,000 people who are now getting comprehensive primary care who had that nothing option before, go to ED or don't get care. So a huge move the needle for them. I just wanted to read you two. They're sort of an amalgamation of patient experiences. So they're illustrative patient experiences. So I'm not breaking any confidences here by reading you this. So I'm going to read it directly if you don't mind. It'll just take me a minute. So the first one is Julie, a 4-year-old child. She woke early in the morning crying. She feels hot and is rubbing her ears, but Julie's family is not attached to a family doctor. Amanda, her mother, calls VTAC and schedules an appointment at the Clinical Assessment Centre on site later that morning. There, a community paramedic provides an in-person assessment, including vital signs, and a family physician who's linked via video is able to do a live ear examination using a digital otoscope. The physician is able to reassure Amanda that there are no serious concerns and gives advice on the correct dosing of simple painkillers. Amanda is relieved that Julie does not need antibiotics and that they have avoided having to go to the emergency department. The second case is Mary, a 72-year-old widow who lives alone and is experiencing cognitive decline. Her son Edward visits daily after work to help with her activities of daily living. One Saturday morning, Mary complains of worsening symptoms that Edward suspects might be a urinary tract infection. Mary is scared of catching COVID-19 or another respiratory illness at the emergency department, and she also worries that Edward misses shifts at work to help her. Instead, Edward calls VTAC and gets a phone appointment with a family physician later that day. Based on Mary's symptoms, the physician confirms the diagnosis of a urinary tract infection and issues a prescription, which Edward can collect at the local pharmacy without visiting an emergency department or taking time off work. A community paramedic is booked to follow up with Mary at her home in a few days' time. The following week, Edward receives a call from VTAC asking if Mary would like to join the integrated virtual care program, attaching her with a family physician and a comprehensive primary care team for her future needs. So like I say, there are two illustrative sort of cases, the elements of which have absolutely occurred with patients over the last 3 years. We currently offer almost 3,000 physician appointments per month, and we have hundreds of on-site assessments with the paramedics, some of which are linked with the physician via video. And like I say, currently at 2,000 patients attached to the integrated virtual care program. My academic role as well has enabled me to sort of do some evaluation of these programs, and we're thoroughly evaluating both of them. We've just had one paper literally 2 days ago accepted for publication about the patient experience with integrated virtual care, which is fantastic. You can imagine, the difference in these patients' lives. And we have another paper currently undergoing peer review that looked at the clinical and economic impact of VTAC. We're very hopeful that we'll continue to get funding and policy approval to keep doing what we're doing, because to be honest, it's been an absolute lifeline for the people of Renfrew County. But perhaps what I also want to show is just how flexible the system is, the model is, and rural areas for sure, but urban areas can benefit from these programs as well. And from my perspective, it's the importance of having a structure in place, a model that works, but that's flexible enough to respond to local needs. So it has to be local driven. For us, paramedics worked fantastically well. For the next county or another region, perhaps another in-person care option is more appropriate. Bigger urban centres have walk-in clinics, for example, and urgent care centres. So that flexibility of locally led care is super important.